bowel symptoms. There was no systemic symptoms along with. Also, there was no history of intake of any drug for prolonged period. Regarding birth history, it was a single term normal vaginal delivery tried at birth. The birth weight was 3 kg, which was appropriate for gestational age, and the perinatal period was uneventful. Regarding developmental history, as depicted by the picture shown by the mother, the child was developmentally normal till 11 years of age, and then the mother noticed regression of motor milestone and language milestone. Regarding family history, it is first by birth order, born out of non-consanguineous marriage, and there was no similar history in his family members or no history of any neurological illness or jaundice in his family members. This is the pedigree chart showing the child, which is of 13 years of age, and the sibling is 3-year-old girl child who is neurologically normal. Now I will be showing some videos of the child depicting the presenting features and some examination finding. All these videos are taken after taking the informed consent from the patient as well as the patient's relatives. So this is the video showing the child in primary position. There are abnormal posturing in his upper limb and lower limb with frequent opening of his mouth with intermittent protrusion of the tongue. On outstretching the hands, there are abnormal posturing of the limbs, mainly the fingers and also the toes, with frequent opening of the mouth and protrusion of the tongue.
পাঁচ সোজা করো দেখি পারো কিনা পাঁচ সোজা করো
On asking to move his leg, there was abnormal posturing also in his legs, and the child could not able to stand or even walk alone. There was frequent opening of the mouth, which was involuntary with intermittent protrusion of the tongue.
নাম কি তোমার
On asking to speak, there was only production of some incomprehensible sound, and the child could not able to talk at all. But the child can play video game as well and can communicate with his family members as well as with us very well. It mainly indicate the relatively preservation of social and adaptive milestone. So now after history and some part of the examination, we will come to the phenomenology part. So it is obvious that it is a hyperkinetic movement. In primary position or at rest, there is frequent involuntary opening of his mouth with intermittent protrusion of the tongue, abnormal involuntary repetitive twisting movement, and the movement are patterned with sustained posturing in upper limb, lower limb, and trunk. In voluntary action, the movement are exaggerated. There was no premonitory arch and the movement are non-suppressible, and they are absent during sleep. Also, there are no other involuntary movement noticed along with. So, as per phenomenology, the movement is described as dystonia. So, regarding description of dystonia under two axes.
Can you
okay.
Go back?
Okay. Sir, which
Just-
slide?
Just describe the videos once.
Okay, sir. From the first one.
Yeah, just tell the phenomenology what you're observing.
Okay. So this is the first video. Where in the primary position or at rest, there is abnormal twisting movement and posturing of his upper limbs as well as lower limbs and in the trunk with frequent opening of his mouth and intermittent protrusion of the tongue. So this mainly indicates a pattern movement which is without preceded by any premonitory arch, and these movements are mainly non-suppressible movements, and as per history the movements are not present during sleep. So these movements are suggestive of dystonic movements.
And they are involving
all the
Yes,
voice
they are
is
involving, they are mainly the generalized dystonia. They are involving the upper limb, lower limb, and also the trunk, and also the oral cavity, oromandibular, and also the lingual, the tongue.
any comments from
Any
Dr.
comments
Sanjay?
from Dr. Sanjay?
Sorry.
Sorry. In
Uh,
pa- uh,
in this patient,
patient,
I think there is some
I think
echo
there
of
is some echo of the
Sir, you are not audible,
I
sir.
think you have to.
I think you have to.
Dr. Boni.
Dr. Boni.
Yes, sir. Yes, sir.
Yes. So
Yes.
just
So just
summarize the finding of
summarize the finding of
So it is a 13-year-old right-handed male child who was first by birth order born out of non-consanguineous marriage with normal birth and developmental history till 11 years of age, who presented to us with features of generalized dystonia along with some neuroregression in the form of motor and language milestone and one episode of seizure as per semiology. This is the generalized tonic-clonic seizure at the age of 12 years of age without any significant family history or any history of any drug intake or any other motor, cranial nerve, sensory and bladder bowel involvement, without any other self-mutilating behavior and other past history or premorbid illness. So this is the summary of the history of this
can you go
child.
to the next
can you
slide?
go to the next slide?
Uh,
Next slide.
Next slide.
Next slide.
Next slide.
No, go to the next
पास
one.
हो
Go
जा
to
करो
the
देखी पारो कि ना
the next slide. Boni.
नेक्स्ट स्लाइड पानी पास हो जा करो देखी पारो कि ना
which slide, sir?
Next
Next
slide.
slide. Next
नेक्स्ट स्लाइड नेक्स्ट
Okay.
slide.
Right.
Just keep the video and
Just
go.
keep the video and go.
Okay, okay, okay. Okay, sir.
Okay. So
Okay,
there
so
are
there
two comments.
Hello.
Neurometabolic disorder
neurometabolic
without
disorders without
Niemann disease
Niemann
type C and
disease type
Wilson.
C and Wilson.
And was there K
Was there cave?
So I am coming to the examination part, sir.
No, what is the
So on
So
possibility
what is the possibility
okay, sir.
at this
Sir,
juncture?
at this junction?
Sir, on examination, the child is conscious, alert, cooperative. General examination reveals no Kaiser facial ring in his eye, no cataract, no neurocutaneous marker, no organomegaly. There is regression of motor milestone and language milestone with some sort of cognitive decline, though detailed cognitive examination could not be done. On speech examination, there is utterance of some incomprehensible sounds only with intact simple comprehension. On fundoscopy examination, there was no features of optic atrophy, no features of retinitis pigmentosa. On neurological examination, there was generalized dystonia with extreme lingual dystonia causing the intermittent protrusion of the tongue. Fissuring of the tongue has depicted by this picture with a hypersalivation. On tone examination, there was rigidity in all four limbs with joint contracture. Sensory examination was normal, DTR was normal, and bilateral plantar was flexion. So this is the in short examination findings, sir. So
Okay, go ahead, go
after
ahead.
history and
Go ahead.
examination, this is a childhood onset, rapidly progressive generalized dystonia associated with other neurological feature like neuroregression and seizure. So probably this is a case of secondary or symptomatic dystonia.
Ravi, you have any
Ravi,
comment?
you have any comment?
We will
We
complete the
will
second case
complete the
also, then
second
we
case
can
also, then
discuss.
we can discuss.
Okay. Okay, sir. So the probable causes of secondary dystonia are such, and in our cases, the probable causes is Wilson first. We must rule out Wilson first. In any case of dystonia with age of onset less than 40 years, then the heritodegenerative group like neurodegeneration with brain iron accumulation and NBI like group. Uh, shall I
If
shall I
you
tell
could,
the
if you could
investigation?
in fast, you can
In
tell it
fast, you
fast.
can tell it fast.
Okay, sir. The investigation finding like complete hemogram PPS shows no acanthocytes, RFT, LFT was normal, thyroid profile normal. The relevant investigation for Wilson workup like slit lab examination, serum ceruloplasmin level, 24-hour urinary copper excretion was normal. Only positive finding we got is the ferritin level, which was low in this case. CSS study was normal, TMS, urinary GCMS was negative, and NCV of all 4 limbs was normal. So now the neuroimaging part. T1 image of brain was normal, but T2 and FLAIR image shows bilateral hypointensity in the globus pallidus, which was symmetrical with central hyperintensity. And GRE image shows the blooming artifact, which was also bilaterally symmetrical involving the globus pallidus. So this is the suggestive of eye of tiger appearance. We performed the genetic study, whole exome sequencing, which revealed no significant, no relevant genetic mutation of NBI group. Rather, we found 2 genes of unknown, uncertain significance. One is a gene of benign hereditary chorea, and other is the HSP type 8. We also performed the paternal analysis, and the parental analysis showed the mother has a WSHC5 mutation with normal phenotype, but father and sibling genetics was normal. So as a whole, the genetic study was negative regarding NBI subvariant. So these are the probable diagnoses in my case. Now moving on to the case 2.
No, so
So should I move?
what is the probable diagnosis?
The probable diagnosis in this case 1, probably it is an NBI spectrum disorder of childhood onset like PCAN, PLAN, BPAN, FHN, MPAN, and COPAN. Though we did not find the relevant genetic mutation of the specific variety. But through the clinical and radiological, as per clinico-radiological finding, our probable diagnosis is NBI spectrum disorder in this case. We got the low serum ferritin value, but the genetic mutation we did not find regarding the neuroferritinopathy, and moreover, the other neurological findings was also absent in this case as per neuroferritinopathy, and it is mainly adult onset variant. So our probable diagnosis in this case is NPI spectrum disorder of childhood onset variety.
Dr. Vikram is asking to show the MRI.
Okay, sir. This is the MRI T1 image. This is
Slowly, you can go slow. And describe. Please describe. So what is the change in Buddha and
So there are bilateral symmetrical hypointensity in the globus pallidus region, which is clear in T1, T2 and FLAIR image with central hyperintensity.
Right.
And in GRE image, there are blooming artifact, which is also bilateral symmetrical involving the globus pallidus region, which is suggestive of iron accumulation. So this typical appearance really gives eye of tiger appearance.
Please have a look at that.
Yes, sir. Yes, sir. I'm trying to figure out.
Dr. Bonni, proceed.
Okay, sir. So moving on to the case 2. So this is a 35-year-old male right-handed smoker without any known comorbidities, presented to us with gradual onset progressive involuntary deviation of his head and neck for last 3 years with intermittent non-suppressible rhythmic jerky movement of his head, which has been stopped in attaining a certain posture after a certain point. There was frequent involuntary blinking of both eyes. The patient developed speech difficulty in the form of disarticulation, undue prolongation of each syllable with intermittent sudden stoppage in between phrases. There is marked distortion of words and marked variation in rate and loudness. There was also abnormal posturing in his upper and lower limb with rhythmic jerky movement in his right hand, both in rest and on action. There was no significant drug history or no family history of similar illness. So this is the video.
বলো তোমার নাম বলো 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 পুরো নামটা বলো আচ্ছা ঠিকানা আচ্ছা 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 আর তুমি গানটা গিয়ে দেখাও একবার
Look at the movement of the mouth. So slow.
So there is deviation of the head and neck towards the right side, which was involuntary with abnormal posturing, and there is frequent touching of his chin and lower part of the face with hands, which is suggestive of sensory trick. There is frequent blinking of the eyes, as well as there is dysarthria, which is hyperkinetic, as well as there is sudden stoppage intermittently in between the face with distortion of the words with intact comprehension. And while singing, all this part of the dysarthria disappears. So this is the examination finding. In rest, there is a tremulousness in his right hand. On asking to outstretch his hand, there is abnormal posturing of his hands, as well as increase of those movements of tremulousness, more in the right side. On asking to open his mouth, there is abnormal posturing of his tongue.
বলো জিভ বার করো
On opening the neck, there is marked bradykinesia. This is the examination of
হাতটা
his
দুধ দিকে কর হাঁটু ঘোরো
and the full test is positive. So, describing the phenomenology, it is also a hyperkinetic movement. In primary position at rest, there is intermittent involuntary turning of head and neck with frequent posturing and resting tremor in his right hand. With voluntary action, all these movements are exercited. In opening mouth, there is twitching movement of his lips and posturing of the tongue. On asking to speak, there is marked dysarthria with aggravation of those movements. And there was a frequent touching of nose and chin with hands while talking, which is suggestive of sensory trick. And all these movements are absent during sleep. Even there is no dysarthria while singing. So this movement phenomenology suggestive of dystonia.
So this is another spectrum, I think. As compared to the first case, age of was the onset age was of onset childhood. was Here childhood. the Here presentation is the a 35 presentation is a percent. 35%. But the spectrum But of the spectrum involuntary of movements involuntary and the movements perioral and the involvement perioral predominantly involvement remains the same. predominantly remains the same. The severity
the
here you can
severity
very
here you
nicely
can very
brought
nicely
out
you brought out
the sensory trick.
the sensory trick.
Visualization was difficult, but
Visualization was difficult, but singing
easy. Easy. So,
so.
Dr. Sanjay, anything?
Dr. Sanjay, anything else?
What is your
What is your diagnosis?
There on summer, there are some part in examination finding. So diagnosis is a generalized dystonia. Probably it is at a late onset generalized dystonia. Probably etiology is secondary, with some other features of Parkinsonism, like in this case, the features of bradykinesia, postural instability, cogwheel rigidity, and also the resting tremor is present. Probably this is a case of secondary dystonia, and my probable diagnosis in this case. So we must first rule out the hereditometabolic cause like Wilson first, and then the neurodegenerative cause like NBI group, and lastly the dystonia Parkinsonism group.
Dr. Boni, I
Dr. Boni,
want to
I want
interrupt
to interrupt
whether it is
whether it
generalized
is
or
generalized or
it is multifocal.
multifocal.
So this is generalized dystonia because there is involvement of trunk as well as two other body parts.
Whether trunk
Whether
involvement
trunk
is too much
involvement is too
significant.
much significant.
So there is generalized dystonia because on examination of gait, there is dystonia in lower limbs, in trunk, in upper limb, as well as in tongue and oral cavity. Also the lips. Also there is frequent blinking of the eyes. So trunk involvement is there, as per my my view,
Okay.
my perception.
Okay, please go ahead.
Okay, please go ahead.
Okay, sir. So on further examining the case, on general examination, there is no cave ring, no cataract, no neurocutaneous marker. The cognition was apparently normal. The speech was hyperkinetic with intact comprehension. There is generalized dystonia. Dystonic tremor in head, wing beating tremor in right upper limb, resting tremor in right hand, bradykinesia, cogwheel rigidity more in the right side than left side. Limb tone was variable. Sensory examination was normal. Deep tendon reflex was normal. Bilateral plantar was flexure. Pool test was positive and cerebral signs were absent. So now the possibilities. So this is a case of late onset, slowly progressive generalized dystonia associated with features of Parkinsonism. Probably it is a case of secondary or symptomatic dystonia. So my more probable causes here is heritometabolic group like Wilson, heritodegenerative group like NBIA with adult onset variant, and Parkinsonism dystonia complex. So this is the table showing the genetic causes of dystonia Parkinsonism syndrome as per age of onset. In this case, our probable genetic cause is this. So we further investigated the case, and the all relevant investigation like hemogram, RFT, LFT was normal. PBS shows no acanthocytes. Thyroid profile normal. All investigation for Wilson workup was normal with normal fundoscopy. Serum ferritin was normal in this case, and NCV of all four limbs was also normal. And MRI brain shows the similar finding, that is eye of tiger sign appearance. So, as per MRI finding, we have found the brain iron accumulation. This suggested some typical genetic involvement. We have ruled out the non-hereditary causes as well, but we could not perform the whole exome sequencing in this case due to some financial constraint. So now, as per clinical and radiological point of view, my probable diagnosis in this case is NBI spectrum disorder with adult onset variant like PCAN, planned neuroferritinopathy. Though the normal ferritin level goes against the diagnosis of neuroferritinopathy, and less likely Wilson aceruloplasminia and neuroacanthocytosis. But the final diagnosis we could not reach as the genetic test we could not perform due to some financial issues. So this is the summary. In case 1, this is a childhood onset progressive generalized dystonia with cognitive decline. MRI brain shows the classical eye of tiger sign. There is genotypic and phenotypic mismatch. We have started the patient on medical therapy, but no such improvement noticed, and the patient has been planned for pallidal DBS. And in case 2, in contrast, it is an adult onset, slowly progressive generalized dystonia with features of Parkinsonism. MRI brain shows the similar finding as the case 1, that is classical eye of tiger sign appearance. We could not perform the whole whole exome sequencing due to financial constraint. We started the anti-Parkinsonian treatment with the triple drug regimen of dystonia, and patient showed gradual improvement with only medical therapy in the second case. So there are different variant of subtypes of NBI group as per age of onset. This is the childhood onset. PCAN, PLAN, BPAN, COPAN, MPAN, and FHN. The young adult and adolescent onset are PCAN, PLAN, MPAN, FHN, Woodhouse-Sakati, and Puffer-Rakoff disease. And the adult onset NBI are adult onset PLAN, aceruloplasminemia, neuroferritinopathy. So all these variants don't show the eye of tiger sign. Only the PCAN, COPAN, and neuroferritinopathy shows the eye of tiger appearance. And there are studies showing the eye of tiger sign having negative PANG2 mutation also. These are the studies done by Hartig, McNeil, Kumar, Staker, and Valento, who have shown that eye of tiger sign may be found even in PANG2 negative variant. And they have diagnosed the case as NBIA, neuroferritinopathy, and MSA respectively. So now the question arises whether we can stamp these two cases as NBI spectrum disorder even with negative genetic finding, or as in first case, or in second case where we could not perform the whole exome sequencing due to financial constraint, or is it anything new? So I would like to make this question open to the house for discussion further.
Yeah,
Dr.
thank you,
Joshi,
Dr. Goni. Both the cases were
Both the
excellent,
cases were excellent,
Thank you,
and
sir.
we will proceed now.
we will proceed
Dr.
now.
Kalyan Bhattacharya is
Kalyan
also on the
Bhattacharya is
panel.
also on the panel.
I would
I would
ask him also to
ask
give
him
some
also to
comments
give
on this.
comments on
These
this,
two cases.
these two cases.
Ravi, can I just
Ravi,
make
can
two
I
small
just make two
comments?
small comments?
Yes, sir. Please go
Yes,
ahead.
sir. Please go ahead.
I'm asking the candidate, have you passed your DM already?
Your DM already.
She is a second year
Second
PG.
year PG.
Or you are doing your
Or you
DM?
are doing your DM.
Yes, sir. I'm second year DM resident.
Second year DM. My question to
My
you
question
is
to you
just
is
a simple question to you.
so
That is, I'm just getting it. But one
Actually,
thing I
your
will
voice
tell
one
you,
is
thing I
breaking.
will tell
It's
said
not
one
you
thing.
said one thing.
Sorry,
Sorry,
can you
sorry,
hear
sir.
me?
I
can
could
you
not
hear
hear
me?
you properly.
Just one comment I will make you.
And I will
You
make you.
finished with the
You finished
statement.
with the statement.
Uh,
Uh,
Sorry,
Now
sir.
I open the
Now I
case for
open the
discussion.
case for discussion.
Didn't you say something like
Did you
that?
say something like that?
Your last line?
Last line?
Mm-hmm. Yes,
No,
sir.
that's not
No,
that's
that's
not
not.
for you to
It's
do.
not for you to do.
That job is
That job
vouchsafed to
is
the
vouchsafed to the
chairpersons. Always
chairpersons.
remember that. The
Always remember that.
chairperson
Chairperson
opens the case.
opens.
It's his prerogative,
It's his
not yours. Okay.
prerogative, not yours. Okay.
Okay, sir.
Now I had a
I
question
had a
which I have
question.
to minimal cognitive
Minimal
impairment
cognitive
to
impairment
moderate.
to moderate.
Hello.
Tell me one
Hello.
thing.
Tell me
I'm
one thing.
sorry.
I'm sorry.
Hello?
Hello. Yes. Good
Hello.
evening,
Yes.
everyone.
Good evening,
I'm
everyone.
Dr.
I'm
Mansi Deshmukh
Dr.
here from
Mansi
the
Deshmukh
IN
here
Digital
from the
team.
IN
I'm
Digital
sorry
team.
to
I'm
interrupt,
sorry to interrupt,
but can I request
but
all
can
the
I request
panelists to
all the
please log
panelists
out
to
and
please
log in
log out
again?
and log in
And
again?
anybody who
And
has
anybody who has
kept the same
kept
program
the same
on
program
any other
on
device
any other
or any
device
other
or
window,
any
please
other
close
window,
it,
please close it,
because that is what is
because that
causing
is
the
what
echo.
is causing the echo.
So please,
So
because I
please,
can hear my own
because I
voice,
can
so
hear my own
somebody
voice,
else
so
has kept
somebody else
the
has
device
kept
on
the
again.
device on again.
All the panelists, please
All the
log out
panelists,
and
please
log in
log out
again
and
and
log in
close
again
all the
and
other
close all the
programs.
other programs.
Asmita, you also log out
Mr. You
and
also log out and
log in again.
log in again.
Dr. Bonnie Sen, you need to
Bonnie
log
San,
out,
you
please,
need to log out, please.
and log in again
Log
using
in
the same
again
link.
using the same link.
Dr. Bhattacharya, may I
Dr.
request you to
Bhattacharya, may I
please log
request you
out
to
and log in
please log
again?
out and log in again.
Now is it better?
Yes, can you hear me now?
Yeah.
Yes, you can hear you.
Yeah, and I think now there is no echo.
Okay. Then we can proceed. Dr. Bonnie.
Yes, let us wait for all the panelists to join again. We have Dr. Bonnie Sen also.
Sir, can I
Yes, I
start?
think
Now the echo is not there, so we can proceed with the discussion.
yes, I think so. Yes, sir. We have now. We don't have Dr. Kalyan Bhattacharya yet, but I think we can begin.
Joydeep, you want to start your presentation?
Yes, sir. I start my presentation. I start sharing, sir. Hello, Bonnie, please.
Okay, sir.
By the time Dr. Jaydeep start his presentation, he asked a very relevant question that what is it, a multifocal dystonia or is it a generalized dystonia? So Dr. Bonnie rightly said that since it is involvement of trunk, it is more likely to be a generalized dystonia. So if we see the current classification, the 2013 classification, the truncal involvement is required to call it a generalized dystonia. And when we say it is generalized dystonia, we emphasize that generalized dystonia with involvement of leg or without involvement of leg. So she rightly said that it's a generalized dystonia in both the cases because there is truncal involvement and both had lower limb involvement. So this is the clarification I just wanted to give to the PGs when they are classifying the dystonia. So the dystonia is classified as focal, segmental, multifocal, and generalized in hemidystonia. Hemidystonia is very important because hemidystonia indicates to a etiology. So suppose you have a hemidystonia on left side, you are thinking of a etiology on the right side. Multifocal is very rare type of dystonia. So majority of them fall in focal, segmental, or generalized dystonia. So most of the time there is leg involvement, but truncal involvement is mandatory. That is to remember. Dr. Jaideep, if you are ready, you can go ahead with the presentation.
Yes, sir. Can I?
Yeah, hello, Ravi.
Yes, sir. Please go ahead.
Yeah, just two things I would like to ask the candidate.
Yes.
Hello.
Yes.
Where is she?
Please go ahead.
You said this is dystonia Parkinson's complex. You said about the second case, didn't you? Dystonia Parkinsonism syndrome?
Yes. Yes, sir. One of the possibility.
Yes, I just
One of
asked you a
the
simple question. You haven't yet passed your DM, but even then I ask you, do you know what is known as Lubag, L-U-B-A-G, Lubag? What is Lubag?
So Lubag disease is a dystonia, genetic X-linked dystonia Parkinson syndrome.
Very, very good. Where do you find it? In which country it happens?
Sir, that I don't know exactly.
It's in India, we never see that. It's found in Philippines, okay? But
Okay,
that
okay,
is one
sir.
thing. In a male subject, since it's X-linked recessive, dystonia with
X-linked.
Parkinson's, that disease always comes up in my mind. And my second question is, you said by the usual three-drug therapy for dystonia. What are the three drugs?
Sir, one is trihexyphenidyl, that is anticholinergic, and the other is tetrabenazine group, and the third one is clonazepam.
No, that's not the classical third drug. What is the classical third drug? And who proposed these three drugs? And what is the name of this particular combination? The third drug classically is pimozide. Okay?
Okay, sir.
Pimozide is not available in many places nowadays. ORAP is the trade name, LARAP is the trade name, but not very frequently found. Ravi, do you get it?
No, sir. No. Here also.
Very difficult to get nowadays. And and yes, that's why we have to use the third drug differently. You are using clonazepam. I have no objection to that. This is, you tell me in which classical disease this combination is used. Classically, in which disease? Is very good response. In which type of dystonia?
Generalized dystonia.
No. A specific condition. A specific dystonic disorder. I give you a clue. It's extremely alcohol responsive.
Okay. Alcohol. Myoclonic dystonia.
Myoclonic dystonia. Have you ever seen a case?
No, sir. Not yet.
If it's possible, one day I will show you 3 cases. 2 in a family and 1 is sporadic case. Anyway, this is a classical condition where this triple drug therapy works, and it is known as the triple drug cocktail therapy of Marsden. David Marsden first used it.
Okay, sir.
That's it. Remember that always. It's classically it's Spinozite. Carry on, Ravi.
Yes,
I'm
sir.
over.
Thank you.
Deep, you can start.
Yes, sir. So good evening to my respected teachers and beloved colleagues. So our topic is dystonia classification and approach. So a definition, dystonia is a movement disorder characterized by pattern, directional, and often sustained muscle contraction that produce abnormal posture or repetitive movement. So I tell again, dystonia is a movement disorder characterized by patterned, directional, often sustained muscle contraction that produce abnormal postures and repetitive movement. In the ancient literature by Hippocrates, also later on, Charcot noted similar cases like dystonia. But the term dystonia was coined by Hermann Oppenheim in 1911 when he applied the term dystonia musculorum deformans to a childhood onset form of generalized dystonia. Flachow and Starling emphasized the inherited nature of the disease in the same year. Later on, May, Hertz, Zeman, Marsden described various aspects of dystonia. Ojelius discovered the gene locus for Oppenheim dystonia in 1989. Pathophysiology, in short, there is reduced and irregular neuronal firing in globus pallidus externa and interna. There is reduced pallidal inhibition of the thalamus, leading to overactivity of medial and prefrontal cortex and underactivity of primary motor cortex during movement. There is also cortical abnormality in the form of enhanced premotor and SMA activity. There is reduced primary motor cortex activity, disorganized sensory motor integration. There is loss of surround inhibition and reduced brainstem and spinal cord inhibition. In the form of metabolism, there is uh, dissociated. Metabolism is dissociated in lentiform and thalamus. In contrary to Parkinsonism, where metabolism is increased in both the region. In dystonia, metabolism is lentiform is increased and in thalamus is decreased. And also there is in the premotor cortex, metabolism is increased. There is excessive activity in the putaminopallidal inhibitory pathway and there is inhibition of globus pallidus internal. So, uh, dystonia is a hyperkinetic movement disorder. So, we need to differentiate dystonia from other type of hyperkinetic movement disorder to diagnose it. First, there is the chorea is another hyperkinetic movement disorder where chorea is a continual, abrupt, rapid, brief, unsustained, and irregular random movement. And ballism is forceful, flinging, high amplitude, involving proximal limb, force, coriform movement. Acetosis is also slow coriform movement. But dystonia is pattern. But in the case of chorea, it is often impossible to predict which muscle will move next. Like we play the video again, which muscle will move next, it is impossible to predict in case of chorea, but in dystonia, it is pattern, repetitive movements in the muscle. Dystonia versus tremor. Tremor is rhythmic, oscillatory, alternating synchronous contraction of antagonist muscle. In dystonia, we can also find dystonic tremor, like in this patient, but dystonic tremor exhibited directional preponderance. There is one side, there is jerk, and there is slower movement in the opposite direction that distinguishes this disorder from sinusoidal oscillation of true tremor. Dystonia versus myoclonus. Myoclonus is sudden and brief jerk, but dystonia is sustained. The abnormal posture also sustained, and there is sometimes repetitive movement. So dystonia is much sustained and patterned than myoclonus. In case of tics and stereotypy, motor tic is sudden, abrupt, transient, repetitive, coordinated movement. It may resemble gesture. Patient may have an impelling urge to perform it, but if he can resist, there is not impossible to resist. In stereotypy, Patients have coordinated, patterned, repetitive, rhythmic, purposeless movement. It may be illogical, like head waving or hand moving, but there is no irresistible urge. Unlike tic, dystonia is not preceded by any urge to perform the movement, nor it is associated with relief once the movement is executed. So there are some characteristics in dystonia. Typically, dystonia is aggravated by voluntary movement, and in action dystonia, the dystonic movements are present only with voluntary movement. When the dystonia is elicited exclusively by particular action, it is called task-specific dystonia. Examples include writer's cramp. Dystonia is worsened by fatigue and emotional stress, and the movements usually abate with relaxation or sleep. Activation of dystonic movement by actions in remote parts of the body is called overt. Occasionally, dystonia may be suppressed by voluntary activity. It is a different type. This is suppressed by voluntary activity. These are named as paradoxical dystonia. For example, dystonia affecting facial and oromandibular muscles is found. Talking or chewing might suppress eye closure in blepharospasm or jaw opening in oromandibular dystonia. Many patients discovered a tactile or proprioceptive sensory tree called gesture antagonist that reduce the dystonia. Mirror dystonia is an unilateral posture or movement that is the same or similar in character to dystonic feature can be elicited usually in the more severely affected site when the contralateral movements are performed. After then we have to there are some disorders if the patient gets the particular posturing or repetitive movement like dystonia, but it is not actually dystonia. When we give the example, will be become lucid. Like in tonic figures, there is sustained twisting movement, and symptoms are paroxysmal. Some patients have head tilt, like if the patient have vestibulopathy, trochlear nerve palsy, or a mass lesion in the posterior fossa. Patient may have persistent head tilt. Deep person syndrome, sustained contraction of axial and proximal limb muscle is present. There are other neuromuscular causes of sustained muscular contraction like
Hello.
Hello.
Sir, sorry to interrupt you, uh, but I request you to please increase your volume of your device. Or if you are using headphones, then please keep your mic closer to the mouth.
Yes. Hello. Whether it is okay now?
Yeah, now it's coming.
Oh, okay. Okay. So there are other neuromuscular causes of sustained muscle contraction like in neuromyotonia, myotonic disorders, inflammatory myopathies, or glycogen storage disease. Carpopedal spasms due to tetany can result from hypocalcemia, hypomagnesemia, or alkalosis. Orthopedics and rheumatological procedures can also involve sustained posturing. In Sandifer syndrome, typically young boys with hiatal hernia develop head tilt in association with gastroesophageal reflux. Now, it is an older classification which describes dystonia into distribution, age of onset, and cause. It changed into the 2013 newer classification with some additional parts, additional attributes were added. So, according to distribution, if it is focal, one body part is involved. Example: cervical dystonia, blepharospasm, spasmodic dysphonia, oromandibular dystonia, brachial dystonia. If it is segmental, more than two contiguous body parts involved, like Meigs syndrome, blepharospasm with oromandibular dystonia, craniocervical dystonia, bibrachial dystonia, when the body parts are contiguous. Multifocal, if it is non-contiguous body part, more than two or more than. Hemidystonia, if in dystonia involve only one side of body. Generalized dystonia, the trunk, and at least two other sides are involved. Regarding age of onset, if it is infancy, birth to 2 years, in childhood, 3 to 12 years, adolescence, 13 to 20 years, early adulthood, 21 to 40 years, late adulthood, more than 40 years. Causes like primary dystonia, dystonia plus syndrome, secondary dystonia, hereditodegenerative diseases, and dystonia associated with other neurological disorders. So in the axis, we describe first axis shows the age at onset, body distribution, both we described in previous slides. With few new things like temporal course, whether the dystonia is static or dystonia is progressive. Variability, like whether the dystonia is persistent throughout the day or dystonia is present when there is some action occurred, like the protruded one upper limb, or dystonia is diurnal, there is any different in morning or evening, or dystonia is paroxysmal, means some activity started dystonia or some triggers started dystonia for a brief period of time. Next point is associated neurological features, isolated dystonia or with other movement disorders, co-occurring neurological manifestation, if present or not. Whether it is isolated dystonia or is dystonia with chorea, dystonia with myoclonus. Another part is co-occurring neurological manifestation is present or not. After this, there is axis 2, which denotes etiology. During denotion of etiology, there are 2 points are taken. Whether nervous system, there is evidence of degeneration or structural changes or no structural changes or degeneration. And then the inheritance. Inheritance can be divided as or it can be inherited, acquired or idiopathic. Inherited case can be autosomal dominant, recessive, X-linked recessive or mitochondrial. Acquired case can be usually all secondary causes are acquired. Idiopathic, when there is sporadic or familial. So our last when the discussion first case, there is age at on age at onset is just adolescent 11 childhood onset or just adolescent onset. Body distribution is generalized. Temporal course is progressive. Progressive variability is persistent. This is progressive and it is present. It is persistent. It is present at rest also, and when the action is occurring, it is similar. So variability is persistent. Associated neurological features, motor and language regression is present. Seizure is present. In axis 2, nervous system degeneration is found in MRI, and inheritance we found there is genetic mutation, but there is no family similar history, so it is sporadic. In the second case, in my opinion, that is the the early adult onset is third decade. Body distribution, in my opinion, it is multifocal. It is less involvement of trunk. So the other body parts not involving trunk, and temporal course is progressive, and it is mostly action specific. When the patient has this, there is no significant dystonia. When the patient is asked to protrude the arm or asked to talk, we found the dystonic feature. Associated neurological features are Parkinsonism. In axis 2, in the etiology, we found the evidence of neurological degeneration in the MRI brain, and inheritance probable sporadic. We have not found the genetic diagnosis, but it is probable sporadic. So in the classification, we get some video for it is a video of focal dystonia, when we can find the right hand having sustained patterned repetitive movement, assuming a particular posture. So there is a dystonia in the right hand. Segmental dystonia, there are two. There is when two or more contiguous body parts. There is oromandibular dystonia and lingual dystonia. When she will be asked to open the mouth, and there is difficulty in closing, and there is tongue dystonia, and then difficulty in closing also, and asked to protrude the tongue, and there is difficulty. In hemidystonia, there is one side of body is involved. When they see the patient asked to hold a posture, then there is right upper limb having dystonic posture, and the right lower limb having dystonic posture, and but the left lower limb has no dystonia. So left upper limb and lower limb has no dystonia, and right upper limb and lower limb having dystonic posture. And the CT scan shows there is hypodensity in the contralateral left thalamus. So there is a two example I can show side by side. There is hemidystonia in the left side. Now it is hemichoria on the right side. Hemidystonia CT scan shows the hypodensity in the left thalamus, and hemichoria is multifocal involvement, also involving caudate and many basal ganglia structures bilateral. So, but in my opinion, this case is multifocal dystonia. So there is non-contiguous body part. And also dystonic tremor is there. And generalized dystonia, this patient having generalized dystonia, when asked to leave the lower lip, he can leave with the dystonic posturing. At the rest, there is also dystonic posturing, and also involve the trunk, upper limb, mouth, tongue, neck. So after getting the dystonia, we have to face some patient with psychogenic dystonia. Some patient may present himself or herself.
Dr. Jaideep, you have to wind up fast. We are running a little bit late.
Yes, sir. Yes, sir. So psychogenic dystonia is abrupt onset.
You can just go through your slides.
Yeah, yes, sir. Yes, sir. So we have to find out whether dystonia is secondary. There is chance of recovery is more in case of secondary dystonia. Some clues are there, like drug exposure, dystonia at rest, atypical site for age of onset, like late onset in adult, annual onset in child, and early onset speech abnormality, hemidystonia, presence of other abnormalities found, non-physiological finding, abnormality, brain imaging, or other laboratory assessment. In case of primary dystonia, only dystonia is found and is mostly focal or segmental, onset in adulthood. MRI brain is normal and no inborn errors of metabolism, mostly genetic disorder. Commonness is open hem torsion dystonia, 90% generalized in Ashkenazi Jews, 50% in other population. There is deletion of gas triplet. There is limb first onset, spread to other side. Onset is less than 40 years of age. There are other DYT 6, 7, and 13 is there as a primary dystonia. Dystonia plus, there is dystonia with other neurological abnormality. MRI brain is normal. There is no neurodegeneration in histopathology. Among them, dopa responsive dystonia is there is a so in case
I
of
think
dopa,
you just go to the conclusion slide, Jaideep.
yes, sir. Yes, sir. So dystonia plus and others are there. So there is dystonia myoclonus, and in case of secondary dystonia, other many causes. It involves the pallidum and thalamus, which can cause dystonia, and the age-degenerative diseases. And so there are autosomal various age-degenerative diseases are there. So we already discussed. So as a part of other neurological disease like Parkinson's disease and other movement disorders are there. So take home message: when patient comes, we have to for a resident, and we have to talk with the patient and evaluate in a calm and quiet place. Videography of the phenomenology with a proper consent. Whether it is a movement disorder, we have to first understand. Then whether it is hyperkinetic, whether it is dystonia. If it is dystonia, we have to approach the patient with diagnostic approach axis. Whether it is primary dystonia plus age-degenerative, secondary, or part of other neurological diseases. Then we have to do a whole exome sequence. As that we can approach the patient as a whole, and according to axis 1 and axis 2, we can diagnose the patient of which category patient may perform. Thank you.
Jaideep, you covered very well. Can you just go to the first two videos of your presentation? I just wanted to emphasize some points.
Yes, sir.
Before we invite Vikram for his presentation.
Yes, sir. Yes.
For the benefit of PGs, first two videos. First two videos. No, not this one. Yeah, yes, please go ahead. Please, yes, please go ahead. Yes, this video. This video, yes. So can we just play this video? So if you see this patient closely, the patient has oromandibulolingual dystonia. And if you can see the side view, the patient has some retro caput as well. So oromandibular and cervical dystonia, that is a two contiguous involvement, and that is a segmental dystonia. So this is a craniocervical dystonia. So oromandibular and lingual, they are considered a single part. So if the patient has only oromandibular and lingual, it is focal dystonia. But if there is a cervical, it will be segmental, because it will be two contiguous part. So this lady has even cervical dystonia. This lady has oromandibular dystonia. Now coming to the second video, please go ahead. Please go ahead. No, not this video. The lady who had a hemidystonia.
Yes, sir.
Hemidystonia, the lady, yes, yes.
No.
This video. No.
This
Previous one. You said the previous one. You said it is a focal dystonia.
No,
The
it's
previous one.
segmental.
No, not this one, the previous one.
Yes.
Yes. So what I'm trying to emphasize, that when you examine the patient, look at the left hand. Look at the left hand. The patient has dystonia in the right hand, but the moment she is doing some activity, there is some dystonia in the left hand. So this is an overflow. And when you examine a dystonia patient, it's very important to examine during some voluntary action and look for some overflow, and ask the patient to do some activity using the non-dominant hand. Like in this patient, you can ask the patient to write from the left hand, because you are thinking that right hand is involved, and look for some mirror dystonia. And also look for sensory trick. That is very useful in focal dystonia. So what I'm trying to emphasize, that even if the dystonia is present only in right hand, there is some dystonia obvious while the patient is trying to do some voluntary activity from the right hand, and that is an overflow dystonia. So overflow, mirror movement, worsening with voluntary action, and dystonia with a sensory trick getting some relief, they are the characteristic feature of dystonia which needs to be highlighted in a particular patient. Okay, Ravi, you have any other comment?
So in the summary slide, just go to the last slide. Summary slide, you had mentioned as a last point as a whole exome sequencing. So, some of the childhood onset or adolescent onset dystonias, like Huntington's disease, Westphal variant, and also in spinocerebellar ataxias, or some of the conditions where CAG repeat length may be required.
Yes,
So it depends on the family history and other things which one you will choose. And it may not be only whole exome sequencing may not give the answer. So that has to be tailor made. Say if autosomal dominant pattern is there or anticipation related conditions are there, then we have to go for triplet repeat disorders also. So otherwise, I think you covered well and in relation to the previous two cases. And so now I think we can proceed, Dr. Sanjay.
Dr. Ravi, before we invite Vikram, there are three questions. I would like these questions to be answered by Dr. Boni. The first question is from Dr. Himanshu. Sir, I have a doubt in middle-aged female with delayed milestone with behavioral issue with generalized dystonia, chorea, and myoclonus. What should be the possibility given that symptoms increased after her menopause? You have any explanation? The symptoms worsened after menopause, Dr. Boni?
Middle-aged. After menopause, the symptoms increased.
Yes. I will like to answer this question. So what happens that many times the patient have a worsening of dystonia as the age advances. but the worsening usually happens within 3 years' time. And most of the focal dystonia is seen during 5th decade, like the cervical dystonia. The mean age is around 53 years of age, and it happens more in females. And there are some hormonal influences which has been reported, like after the menopause, the estrogen influence is no more there. And there is a hypothesis that may be responsible for the worsening of dystonia. Dr. Boni, the second question, can you show the 3-generation pedigree chart of second case? Was family history negative for movement disorder? Do you have any answer for
The
this?
family, sir, family history was negative. 3 generation pedigree chart, there was no history of similar illness or any other neurological illness or jaundice
Okay.
in the second case.
Okay. Third question by Dr. Sekhar. Athetosis term exists or not? So just for the benefit of the participant, athetosis term is there, and it is a slow rising movement. It mimics like dystonic movements, but it is mostly used in the context of perinatal hypoxia. And sometimes it may be secondary to some spinal cord pathology also, like we see pseudo-athetoid movement in patients of myeloneuropathy. But what is very important that athetosis is usually not an isolated movement, and it is seen with chorea. And then we say it is a chorioathetoid movement. And sometimes it is combined with dystonia. So we say it is a chorioathetoid dystonic movement. So athetosis is a very rare movement, but its presence is indicative of hypoxic injury during the childhood. But if it is present only on one side, it may be indicated of a spinal cord pathology. So with these comments, Dr. Ravi, can you invite Dr. Vikram?
Yeah, so next talk will be by Dr. Vikram. And in relation to this, 2 cases and discussion, he will be presenting on approach to NBIA disorders. And Dr. Vikram is Associate Professor of Neurology at NIMHANS. Dr. Vikram, you can start.
Dr. Vikram, you have only 15 minutes for presentation and 5 minutes for discussion. Please go ahead.
Thank you, sir. Is my screen visible and my voice audible?
Yes, sir.
Yes.
I'll quickly go ahead with the presentation. So I have just taken the liberty to include also the MRI in the approach to NBI spectrum disorder, because almost every time it is the MRI that is very helpful in these disorders. So just coming to the clinical scenarios, like all the scenarios that I have enlisted can have NBI spectrum disorder as one of the differential diagnoses. Like it can be childhood onset, craniofacial predominant complex dystonias, or a toddler with hypotonia and neuroregression, which can present with INAD. Juvenile onset levodopa responsive dystonia, Parkinsonism, adolescent to adult onset focal dystonias, which can be seen in KMT2 peak and sometimes adult onset hyperkinetic movement disorders, spastic ataxic syndrome, cognitive and behavioral impairment with extravehicular syndrome like MPAN plan. So all these clinical scenarios can have NBI spectrum disorders can present with all these varied clinical scenarios. So just a brief, NBI is a relatively rare, that is neurodegeneration with brain iron accumulation, relatively rare and have an incidence of 1 in 1 million. And it is clinically, radiologically, and also genetically heterogeneous inherited group of neurological disorders. It is unified by the abnormal accumulation of the iron in the brain, in the basal ganglia. However, it is not universal, and some cases may have no iron accumulation at all. That is why this term is being questioned these days. And it is considered as an inborn errors of metabolism affecting various biochemical pathways. And it can be primary iron homeostasis related defect, or it may be just a secondary iron deposition also. So newer and newer genes are being identified which can have a similar radiological manifestation as classical NBA genes. So coming to this, it can be subdivided by pathomechanism. Coenzyme A synthesis defect is seen in PCAN, which is the most common NBI disorder, which is seen in around 50% of the NBI spectrum disorders. Apart from that, COPAN and recently described SCP2 and CRAT, that is carnitine acetyltransferase enzyme defect, also can cause NBI type disorders. Plan, that is phospholipase A2 neurodegeneration, which is the second most common NBI, is a disease where there is phospholipid metabolism defective. And coming to the iron metabolism, the pure iron metabolism is a neuroferritinopathy, where the light chain of the ferritin is defective, and aceruloplasminemia, where ceruloplasmin production is defective. So these are the only two disorders which are directly related to the iron metabolism. And defective autophagy can be seen in BPAN, that is beta propeller protein related neurodegeneration, or Kupffer-Jakob syndrome. And also recently described REPS1 and AP4M1, which is SPG50, can also have autophagy defective. And there are certain other causes where the mechanism so far is unknown, like Widow-Sakati syndrome came to unknown mechanism, where the iron accumulation is not known why it happens. So coming to this slide, as you can see, among the NBA spectrum disorder, PCAN considered around 50%, followed by Plateau J6, then MPAN, BPAN, and rest are made by the rest of the causes. So coming to the clinical approach, usually we approach by age at onset, inheritance, progression, and the phenomenology of the movement disorders, and associated neurological findings, and also the systemic involvement. This is the usual approach that we use for most of the neurological disorders as well. So coming to the age and inheritance. So age at onset is one of the very important thing. Most of the NBA disorders manifest in childhood to early adolescent onset, whereas Plateau J6 related INAD that can present in the infantile onset, 6 months to almost 1 to 2 years, the typical manifestations, whereas atypical or juvenile onset can have childhood onset. Whereas when it comes to adult onset, we have to consider neuroferritinopathy, aceruloplasminia. These have predominantly adult onset presentation, whereas atypical PCAN, atypical PLAN, and MPAN also can have adult onset presentation. Progression, most of them are all relentlessly progressive, whereas one point to be noted is a BPAN that is caused by WDR45 mutation. It is also earlier called as static encephalopathy with neurodegeneration in the adults. So this can have a biphasic progression, like they may present as maybe cerebral palsy, like static encephalopathy early childhood. Thereafter, in the adulthood, there can be sudden worsening with dystonia Parkinsonian presentation. So we need to consider one of the DD where there is biphasic progression. Coming to inheritance, almost all of them are autosomal recessive, whereas two diseases that has to be noted is BPAN, that is beta propeller protein associated neurodegeneration, is an X-linked dominant. And whereas the Widow-Sakati, the neuroferritinopathy is one of the only autosomal dominant inherited disorder among the NBA spectrum disorder. MPAN has both autosomal recessive and recently autosomal dominant has also been described as a mode of inheritance. So major approach will be based on how the movement disorder phenomenology is in a particular patient. Predominantly, it is either dystonia or Parkinsonism. And whenever there is a childhood onset dystonia, which is predominantly combined, there will be other movement disorder or other neurological features or other systemic features. And often craniofaciobulbar predominance will be there. One of the first things that we have to consider in such cases is the PCAN, as already described in the previous two cases described by Dr. Boni Singh. And apart from that, CoPAN also can have very similar presentation as PCAN. Neuroferritinopathy, aceruloplasminia, all this can have a predominantly dystonic presentation. One of the focal dystonia, like oculographic dystonic spasm, the upward turning of the eyes with the retained sensorium, is one of the classical feature of Kupffer-Jakob syndrome. So whenever such symptoms are there, although it is commonly seen as a drug-induced, but among the NBA disorders, if we have to consider, it is the Kupffer-Jakob syndrome that can have an oculogaric dystonic spasm. Limb onset dystonia can also happen, such as in MPAN, where it can be lower limb predominant, and neuroferritinopathy, PPAN, atypical PLAN, and atypical PCAN can all have limb focal onset dystonia, isolated dystonia as a presentation. Parkinsonism is one of the second most common or almost equivalent to dystonia itself. So we can have Parkinsonism in Plateau J6 related neurodegeneration, otherwise called as PLAN, or mitochondrial membrane associated protein associated neurodegeneration, otherwise called as MPAN. Kupffer-Jakob syndrome. PCAN also can have dystonia Parkinsonism. Neuroferritinopathy, aceruloplasminia can have rarely Parkinsonian manifestation, and Kupffer-Jakob syndrome can have a Parkinsonian manifestation. So among these, Plateau J6 and Kupffer-Jakob can have levodopa responsiveness and also very early dyskinesias. So they usually manifest as an early or young onset Parkinsonism with relatively good levodopa responsiveness and also early dyskinesia, but it's not universal. Others also can have variable levodopa responsiveness, and it may vary patient to patient. Chorea is one of the typical manifestation in neuroferritinopathy and aceruloplasminemia. These two occur in the adulthood. So one of the DD that we can consider as HD or HD-like illnesses, neuroacanthocytosis. Neuroferritinopathy being an autosomal dominantly inherited. So they can be confused with HD sometimes, but the MRI will be a clincher in such cases. And ataxia is also one of the manifestation, especially in Plateau J6 related neurodegeneration or fatty cell FA2H related neurodegeneration, where it can be spastic ataxia syndrome, one of the predominant manifestation. And alceruloplasminemia can also have ataxic manifestation because of the mineralization of the dentate nucleus and cerebellum. So apart from the movement disorder phenomenology, we have to also consider the other neurological signs, which is very important because this is where most of the time the clue remains, by use of which we can guess, or we can keep a differential diagnosis what it can be among the spectrum of NBIs. So seizures are common in later part of the illness in INAT plan and BPAN also. If the patient infantile onset neuroregression, hypotonia, muscle atrophy, and also neuropathy, one has to consider especially infantile onset INAT plan. Visual impairment is a classical feature, like retinal degeneration can be seen in PCAN or erythroplasminemia. Optic atrophy is one of the feature in FA2H related neurodegeneration, PCAN, plan, and MPAN. So if a patient comes with where we are suspecting NBA based on either clinically or radiologically, and one of these optic atrophy is there, these are one of the 4 DDs. And based on a clinical feature, if it is a spastic ataxia syndrome, FA2H and plan will be one of the high on the differential. If the patient has predominantly dystonia, PCAN more likely to be degeneration rather than optic atrophy. And strabismus can be seen in the INAD. And deafness is one of the clinical classical feature that we can see in Woodhouse-Sakati syndrome, where we can it also has alopecia, which I will be showing in the later slides. Spastic ataxic syndrome, if the patient has significant spasticity, FA2H related neurodegeneration, and plan are one of the NBS spectrum disorder that one has to consider. Apart from that, recently described AP4M1, which is labeled as SPG type 50, they can also have spastic or a spastic ataxic presentation. Cognitive impairment is classically, very significantly seen in MPAN, where the patient adult onset also there may be significant psychiatric comorbidities, MPAN and platogenesis also. Sometimes we have seen cases where the patient was being treated in the psychiatry unit, and thereafter, after the MRI, the patient was transferred to us because of the classical MRI features. And sometime in plan, there is platogenesis related neurodegeneration. MRI may not show iron accumulation also. So sometimes the patient may go undiagnosed for a very long time till the patient may develop Parkinsonism, which initially we may think it is drug induced, but only with other features we may consider, like there may be cerebellar atrophy, which is very sensitive sign in platogenesis related neurodegeneration. So in such cases, we may consider it as plan related and may advise for exome sequencing. And OCD symptoms, stereotypies, autism spectrum disorder like manifestation or Rett-like manifestation can be seen in BPAN. Neuropathy is one of the features that can be seen in BPAN and MPAN. So these other neurological signs that are there will help us in fine-tuning our list of differential diagnosis and investigate accordingly further. So there are some systemic involvement as well. Aceruloplasminemia is actually a triad of movement disorder and retinal degeneration and diabetes. Because of the iron deposition in the pancreas and also in the liver also, these patients can have systemic involvement as well. And when a patient of movement disorder comes with hypogonadism and MRI showing iron deposition, Woodhouse-Sakati syndrome is one of the things that one has to consider. And hair changes, again, alopecia is seen in Woodhouse-Sakati syndrome and frizzy hair in FA2H related neurodegeneration. I'll be discussing some of the cases. So just, briefly, so this is the flow chart. So as I said earlier, in a suspected case of either clinically or radiologically, suspected case of NBA disorder, first thing we will look at is family history, apart from the age at onset. If the family history is there, autosomal dominant inheritance, one has to consider neurofiltropathy and high on the differential list. If it is X-linked dominant inheritance, then Senda syndrome or the BPAN. So they are both the same. So this has to come in the differential diagnosis high in the list. Autosomal recessive inheritance most often may not have a positive family history, or they may have autosomal recessively type of family history. In such cases, all the other disorders will come into picture. The patient has significant cranial bulbar dystonia, retinitis pigmentosa. As I already told, PCAN is high on the list, and it is the most common type of NBA disorder. If the patient has neuropathy, optic atrophy, and cerebellar atrophy on MRI, it is very likely to be plateau G6 related neurodegeneration. And eye of the tiger sign on the MRI brain, as demonstrated in the 2 cases that was discussed before. So this is almost always pathognomonic of PCAN. There are some imaging phenocopy which I will show later, mention later, but the classical feature, I mean, clinical presentation of combined dystonia, predominantly craniobulbar, along with eye of tiger, is almost always PCAN unless proved otherwise. So even without a genetic testing, this will be very likely that it is PCAN unless proved otherwise. In very rare cases, it can be other causes also. Diabetes mellitus, because of the iron deposition in the pancreas in aceruloplasminemia. So diabetes mellitus can happen, and aceruloplasminemia has to be considered. As I told earlier, Upgaze palsy and facial myoclonus and dystonic oculogaric spasms, Parkinsonism, dystonia of a patient is especially childhood onset. One need to consider Kupffer-Rykop syndrome. Although initially it was initially described in a very, a close locality in the West Asian country. Now the cases have been described all over the world, and even in India, 4 to 5 cases have been already described. Spasticity, dystonia, optic atrophy again, and cognitive decline. Cognitive decline is of the hallmark of MPAN. So many times cognitive decline and psychiatric symptoms come first before the other movement disorder manifest. So MPAN has to be considered. And as I told earlier, FA2H and LAR2G6 should be high on the list if a patient comes with a spastic SPG-like presentation or spastic ataxic syndrome-like presentation. And both can have optic atrophy also, cerebellar atrophy also. MRI may, up to a certain extent, help in differentiating these two. However, clinically, it may be very close differential, and it will be difficult sometimes to differentiate without a genetic testing. And if a patient with hypogonadism, deafness, alopecia, diabetes mellitus also can happen. So almost always very likely, if a patient has iron deposition, it is very likely that the case we are dealing with is Budo-Sakati syndrome. And as I told earlier, in NBA, it is predominantly clinical and MRI, because MRI is the one that will sort of help us in suspecting a case, NBA spectrum disorder in a case, and the pattern of iron deposition will also help us in identifying which may be the most likely cause. Like as mentioned earlier, eye of tiger appearance is almost pathognomonic of PCAN, but all cases of PCAN may not have eye of tiger appearance. Around 10 to 15% may not have the eye of tiger appearance, and it may develop later. So when we image the patient is also important. In the early stage, the eye of tiger appearance may not be there. So just because it is absent, it doesn't mean it is a PCAN. In a rare instance, it can be absent. And I'll be showing the images later. T1 substantia nigra hyperintensity. So only one image, if there is halo sign in the T1 MRI sequence, then one has to think of BPAN or SENDA. And T2 white matter hyperintensity with alopecia, Budo-Sakati syndrome, with cerebellar atrophy, it can be PLATO-G6 or FA2H. Brainstem atrophy may or may not be there in FA2H, but white matter hyperintensity and cerebellar atrophy, one need to think of PLATO-G6 or FA2H. And T2 hypointensity of the caudate, putamen, thalamus. Usually in the MBS, it is the either GPI is the most, GPI and SNR is the most likely involved. When the patient, there is caudate, putamen, and thalamus is also involved, then neuroferritinopathy and aceruloplasminemia. These are the two most likely diagnoses that we have to consider. In them, there will also be cortical pencil lining. I'll be showing the MRI later. So this is the MRI approach. So just a clinical vignette. As discussed earlier, this is again a case of childhood onset generalized dystonia. As you can see, there is very severe cranio-oromandibular dystonia or jaw opening dystonia is there, and also upper limb also. It is a generalized dystonia. And the patient had severe anarthria and was completely dependent for all ADLs. So if we go by the clinical details, childhood onset dystonia with predominantly craniofacial generalized dystonia. So NBA will be high on the list, and among the NBAs, PCAN will be high on the list. And so MRI was showing eye of tiger appearance, and genetics also confirmed that this is a case of PCAN. So in the PCAN, these all I have already described. Classical PCAN is usually early childhood onset, but there can be atypical PCAN that can have onset after 10 to adolescent or adult also, where it may be predominantly focal dystonia or multifocal or segmental dystonias also. And this is bullous maculopathy, pigmentary retinopathy, optic atrophy can also be seen. So one clinical feature that you have to look for is what is called as praying mantis sign. So because of the oromandibular dystonia, the patient have a tendency to, in the gestate, that they will be touching their jaw by the hand. So that looks like a praying mantis sign, as you can see in this kid and also in this patient. And there may be severe dystonic opisthotonus. Again, any patient with severe dystonic opisthotonus, one has to consider NBA syndrome. And as I mentioned earlier, sometimes it may have a late onset also. This patient had a very long-standing isolated generalized dystonia, and this patient also. So both the patients were genetically proven, radiologically proven PCAN cases. And that's what, it need not be always childhood onset. Sometimes it may be adolescent to adult onset also, and it may be relatively isolated dystonia can also be the presentation. And one more thing, this is a patient of young onset Parkinsonism who had levodopa responsiveness also, but she had significant cognitive decline and peripheral neuropathic features were also there. So that was odd for usual causes of genetic Parkinson's disease, like the one that are listed, like a Parkin or DJ, all those things. Cognitive decline was very significant. And as you can see, there is asymmetrical Parkinsonism, mild dystonia also. And the MRI showed very subtle mineralization of caudate, putamen, and GPI, and significant cortical and cerebellar atrophy also was there, as you can see. And this is the sign, one of the signs that we may have to see. This is a case of plateau G6 related neurodegeneration. This is called as clavum hypertrophy. This is one of the signs that can be seen in few cases of the plateau G6 related neurodegeneration. The thickening, this is a clavum will be very hypertrophic. It is sort of sometimes subjective. So sometimes it may look like it is hypertrophy, but this is one of the signs that can be useful, especially in INAD cases, it is more often seen. And as mentioned, this is again siblings with plateau G6 related neurodegeneration, where the patient had very slow tremor, looks like probably cerebellar component also in that, and upgaze restriction. And also there was myoclonus, facial myoclonus. Facial myoclonus is usually feature of Kupffer-Jakob syndrome. Initially, we thought these two cases are a case of Kupffer-Jakob syndrome because of the severe atrophy, cognitive decline, mineralization, and facial myoclonus. But it turned out to be plateau G6 related neurodegeneration. As you can see, there is significant atrophy and also basically mineralization. So plateau G6 can have 4 to 5 different types of manifestation. As I told, INAD, atypical INAD, spastic ataxic syndrome, isolated, pure dystonic syndrome, and dystonia Parkinsonism syndromes. And it depends on the age of onset also. It can start from early infantile to adulthood. So it has a very varied presentation. This is a kid around 10 years old with a 4 to 5 years history of progressive walking difficulty. And you can see mild dystonia is there in the fingers, and she had subtle cerebellar signs. But predominantly the patient had spastic gait. So it was predominantly spastic syndrome with some amount of minor, you can see the striatal to minor distal dystonia. So predominantly spastic, you can see this very severely spastic gait. So she had a spastic syndrome with some amount of ataxia and dystonia. And the MRI, again, as you can see, it is showing mild mineralization of the GPA, significant white matter hyperintensity periventricular predominantly posterior, and severe cerebellar atrophy and some amount of pons atrophy also. There is also optic nerve atrophy. So predominantly this early of childhood onset spastic ataxia syndrome with NBA, one has to think of FA2H, which this was a genetically proven case of FA2H. So it may look like plateau G6, but usually spastic ataxia syndrome is uncommon in plateau G6, and usually it is in the adolescent adulthood. This patient was a child. When a childhood onset, such presentation with mild mineralization, sometimes it may not be there also, mineralization. Cerebellar atrophy, optic nerve atrophy, and also white matter hyperintensity, you have to think of FA2H. And some other cases like MPAN. In the MRI, it is, as I told earlier, it can
Bikram,
be...
Dr. Bikram, you have hardly any minute left now. So
okay, sir, just 2-3 images I will show and just finish
yes,
up. That's
yes.
3-4 slides
Yes.
are there. So,
yes.
so here MPAN, again GPA, you can see this splitting of the GPA. So this is one of the classical feature of MPAN, but it is seen only on 20 to 25%. So you do, if it is absent, it doesn't mean it is not MPAN. And these are the classical feature, as I told earlier. This is the T1 hyperintensity along the substantia nigra. This is the halo sign that can be seen in BPAN. And here you can see caudate, putamen, thalamic involvement, and dentate involvement in the aceroplasmin. It will be florid mineralization. And this is called as cortical pencil lining. So this is what is seen in, it can be seen in aceroplasmin also, or neuroferritinopathy. You can see this mineralization along the cortex. And this is a case of Woodhouse-Sakati syndrome. Just to show this classical alopecia the patient has, sort of the, forgot the term, the lateral alopecia will be there. The patient had hypogonadism, mineralization, and white matter hyperintensity. And he also had a deafness. So eye of tiger phenocopy, carbon monoxide intoxication, neuroferritinopathy, MPAN, and Wilson disease can happen. But usually the clinical feature will be, other features will help us in differentiating. Other than that, GM1 gangliosidosis, KMT2B also can have mineralization. This is the case of KMT2B. You can see this GPI mineralization, but they will have this sort of a splitting again. But the posterior part will be narrow. So this is also maybe considered as the MBA syndrome, and you can see the bulbous tip nose, that is very classical elongated faces of KMT2B. And this is, again, you can see the mineralization in the GPI. This is a genetically proven case of GM1 gangliosidosis, but you also should see the posterior putamen hyperintensity is there in this, and it is atrophic. So GPI mineralization with posterior putamen atrophy, it should consider GM1 gangliosidosis rather than any of the other MBA disorder. And they will have classical facial myoclonus, this one. So this is very classical of GM1 gangliosidosis, very slow myoclonus. So this is just a gist of the MBA disorder, clinical and to a certain extent radiological presentation. So one should understand this is very clinically, radiologically, genetically heterogeneous. So although it was initially termed together because of the brain iron accumulation, it can be seen in various other disorders also, and also in Parkinson's disease, MSA, other acquired causes also. So now it is more likely to be inborn and also metabolism than NBA. So the terminology is sort of in question. And apart from the movement disorder, the associated neurological and systemic involvement gives us a clue, which we have to look for, like for instance, deafness or hypogonadism or diabetes mellitus. And they can have spastic ataxic syndrome, and the pattern of iron deposition, and also the other abnormalities like optic atrophy, cerebral atrophy, or spinal cord atrophy in FA2H will also help us in thinking which will be the most likely cause. And one should understand that iron deposition is not always universal, especially FA2H and PLAT2G6 may not have iron deposition, especially in the adult onset or if it is imaged early. So thank you, and this is our team at Nimas, and thank you, sir.
So I really appreciate, Vikram, you presented very well with all the videos and genetic finding. We have only one question. Does PLAT2G6 have pyramidal involvement? Yes, PLAT2G6 is a broad spectrum disorder, and there is another terminology known as pallidopyramidal syndrome. And most of the NBIA were classified as pallidopyramidal syndrome if you see the previous paper, but there are other differential, like sometime in HSP patient, we get a similar presentation, pallidopyramidal syndrome. In the interest of time, I just thank the presenters, and I request Dr. Rabi to have any final comments before we conclude.
So I think today we saw the spectrum of cases from the beginning when Dr. Boni presented, and then the approach to dystonia, and then Dr. Vikram presented the approach to NBIA disorders. But for the PGs, the message is that first and foremost, you have to try to characterize the patient, age of onset, and then see the dystonia, what is the phenomenology of dystonia, which parts are being involved. As you saw, the dysarthria, dysphagia was early, and then the first patient had generalized dystonia, but the second patient was a little different in the. So the two messages are NBIS can occur early and late, both. Characterize the phenotype, and then because in the exams you will be asked to approach in basically the phenomenology wise. And theoretical part also we have discussed. If the students have any suggestions, they can email to us, and we would in future we would try to take up those cases which are more relevant for exam purposes. So with this, Dr. Sanjay, any other thing should we close?
I think we should just thank the presenters. They did very good job. And in future, we are going to have more such activity. And with this, we conclude the current session.
Thank you, sir. Thank you, sir, giving us
Thank you, everyone. Thank you, Vikram, Joydeep, Moni, and also Dr. Kalyan Bhattacharya, who joined briefly, and also the IN admin. Thank you.
Okay, thank you.
Thank you, sir. Thanks, everyone.